College of Medicine, who's hosting our speaker today, Dr. Darrell Gray II. Dr. Gray is an associate professor of medicine in the division of gastroenterology, hepatology, and nutrition at the Ohio State University College of Medicine, and plays many roles there. He is a deputy director for the Center of Cancer Health Equity, also the medical director of Healthy Communities at OSU as well. In 2017, Dr. Gray was part of the class recognized by the National Minority Quality Forum 40 Under 40 as leaders in health. And you may have caught some of his content on YouTube, and has been very outspoken and a promoter really for community building and anti-racism action plans and efforts. So it really is a pleasure to host and to have Dr. Gray share some of his experiences and stories with us today. And I just have to comment or mention, he joined us an hour ago too, where his lecture was focused and directed more toward students and postdocs, and just really had a wealth of insight and experience to share with them, not only the students, but also their mentors. But we look forward to this hour to hearing Dr. Gray talk more about advancing health equity through this type of partnerships and anti-racism. So Dr. Gray, thank you again for joining us. This is wonderful to have you, and we look forward to your talk.
Thank you so much for that introduction. I am so excited to be with you. I'm not in my typical place. I'm actually out of town, and I say that only just to ask your forgiveness if there are technical difficulties. I may cut it in and out during this presentation, but I promise to come back. I'm not going to leave you. So I'm looking forward to being with you. Please save your questions and answers, if you wouldn't mind, to the end, and I look forward to our Q&A period together. I don't have any relevant financial disclosures for this talk, but similar to the last talk, I want to tell you a little bit more about myself that may not be gleaned from my bio that Stephen very nicely read and echoed. So I'm a man of faith. I'm a father and a husband of almost 11 years. I have 3 kids. That's a little bit older picture, but I have a 6-year-old Harper, a 4-year-old, actually Harper's about to be 6 next week, but a 4-year-old Ella, and an almost 2-year-old Noah. I'm a physician. I have an active clinical practice, but also I'm a physician researcher and administrator. So the majority of my time is really spent in leading teams now across different strategies across our College of Medicine and our health system and health sciences colleges, but also I'm a community advocate and really work towards translating the voices of community members to action and systems and strategies. Today, we're going to cover a couple of things. We're going to distinguish social and moral determinants of health through a health equity lens and identify ways to incorporate them into practice, and identify how the application of moral determinants of health through community engagement can advance health and scholarship. And one thing that's not written there that is an objective for today is hopefully you identify one thing, at least one thing that you can apply to your current work and be a champion in that area from what we discussed today. Well, it's Black History Month, but it's always a good time to share quotes from Dr. Martin Luther King. He said, "We're now faced with the fact that tomorrow is today. We are confronted with the fierce urgency of now. This is no time for apathy or complacency. This is a time for vigorous and positive action." Certainly, as we explore the urgency of now, we got work to do, y'all. And we compare ourselves as a nation, United States, to other wealthy and similarly economically developed nations. And guess what? We have lower life expectancy, despite us spending more per capita GDP on healthcare than any other nation. We have lower life expectancy, higher obesity rates, higher chronic disease, suicides, avoidable deaths, and hospitalizations from preventable causes. It's urgent. We have work to do. And sometimes as we think about these things, we think about them in silos, and we look at our data sheets and we look at these statistics and we don't put faces by them. But I want to put some faces next to these. So as we look at life expectancy from 1970 to 2016, and you look on the left and you look on the y-axis, you see age in years, and at the top to the left of the graph, you'll see a beautiful white baby girl. You'll see a beautiful black baby girl. That was actually Harper when she was just a couple of months old. You'll see a beautiful white baby boy. You'll see a beautiful black baby boy. But what you can also appreciate when you look over at the graph, there's significant disparities in life expectancy that are based on race and gender. 10 years difference from a white female and a black male. And let me take you to Ohio, where I live. I'm in Columbus, right in central Ohio, and we are poorer, less educated, and less racial and ethnically diverse than other aspects of the nation, but there are disparities there. We particularly have some unique populations, such as our Appalachian population, which is 32 of our 88 counties that span East and South Ohio, geographically isolated, socioeconomically distressed, and a healthcare professional shortage area. We also have the second largest Somali population to Minnesota in the nation. We also have a large Amish and sexual and gender minority population here. And there are disparities across all of these groups. But particularly if I zone in Ohio into where I live, to where I actually work in Columbus, particularly around the Hilltop area, where there's 61 years life expectancy. And I contrast that just a few counties away where it's 88 years. So over 25-year life expectancy difference. But let's just zone into that county, my county, Franklin County. And even within the county, just a couple streets away, we can notice a 20-year difference in life expectancy. You know, this brings to recollection a quote from Sir Michael Marmot, who is a noted epidemiologist, who says, your zip code is more predictive of your life expectancy than your genetic code. And we are certainly seeing that bear out today. And so I couldn't resist. I'm a gastroenterologist. Let me zoom in through the lens of colorectal cancer for a second. If we think about mortality from colorectal cancer, it's the second leading cause of cancer-related deaths amongst men and women in the United States. And we have made progress. The graph on the left is mortality from colorectal cancer, years of death on the x-axis, rate per 100,000 population on the y-axis, and then you can appreciate the lines that signify racial and ethnic groups. And what you can appreciate, although we've made progress over time through innovation, particularly implementation of colorectal cancer screening programs, we've been able to decrease mortality from colorectal cancer. But racial and ethnic disparities persist. The gap persists. But this is not just about race. I don't want to give that illusion. Certainly, we talked about geographic differences. And in this, you can see United States, red is bad. Red is higher mortality. And you can see that there are certain pockets where the mortality is highest. So again, zip code more predictive of life expectancy than genetic code. But let's think about education. What about education playing a role in this? Let's look at this graph. If I identify myself right here in the middle as a non-Hispanic Black person who's had greater than 16 years of education, my risk of dying from colorectal cancer is higher than someone who is Hispanic with less than 12 years of education, someone who is white, who has greater than 16 years of education, 13 to 15 years of education as well. So it's not just about race, it's not just about where you live, it's about education as well. Well, what about insurance? Sometimes insurance can be a surrogate for poverty. Certainly, as we think about those who are on Medicaid or who don't have insurance, we think about those people as those who lack or have low income. And if we look at survival from colorectal cancer is across stages. Stage 1 means it's basically localized to the colon. Stage 4 means it has spread elsewhere, like the liver, the lungs, the brain. And we look at any stage of colorectal cancer and we see that the survival is lower amongst those who have no insurance or on Medicaid. Again, those who live in poverty. But let's zoom out. 2021, the COVID-19 pandemic. And certainly, as data was starting to come out in February, March of 2020, and has continued, we see significant disparities in the cases, hospitalizations, and deaths as we compare Black and Indigenous people of color to white. And we see a significant disparity in those who are dying, but also a pandemic that has far outlived COVID-19 has been racism and systemic inequity. And this came to a global outcry in the summer at the death of George Floyd, but know that there have been far more 8 minutes and 46 seconds than what happened with Mr. George Floyd. And so as we think about the tale of two pandemics, certainly as we were thinking about COVID-19 when it was first starting, people were saying, well, I can see why more Black and Indigenous people of color, racial ethnic minorities are dying from COVID-19. Well, those are because they also have a higher prevalence of heart disease, diabetes, cancer, poor mental health, and that's true. But what leads to those things? Those are just the symptoms. We got to think about those determinants that lead to those things. It's the housing insecurity. It's those who are predominantly, again, if we think about our essential infrastructure workers, the taxi drivers, the grocery store workers, those that can't limit, in-person interaction, those are racial and ethnic minorities. We think about those who live in unsafe and overcrowded housing. Those are racial and ethnic minorities. We also think about income inequality and food insecurity and poor access to quality care, but also, what are some of the things that led to that? We think about poverty and racism and discrimination. And we think about these things often, and people, in talks, people will say, well, Doc, don't you think that wealth or education is protective from racism? Well, many of you may have heard of Dr. Susan Moore. She was a Black female physician in Indiana who contracted COVID-19 and publicized her experience with COVID-19 in the hospital. And she said, I put forth and maintained that if I was white, I would not be treated like that. And she ultimately died. She was talking about racism and discrimination while she was being treated for COVID-19, which she felt was inadequate treatment. I also think about other people, like one of the most wealthy health executives in the nation we lost over a year ago, Bernard Tyson, who led Kaiser Permanente. And he died relatively young. So we think about the impact of racism over time causing this, what we call weathering over time, or allostatic load that contributes to these downstream health outcomes. But part of what we're talking about is social determinants of health, the conditions in which people are born, work, age, play, and inequities in power that influence those things. So certainly as we think about work that we do in the clinic, know that, and evidence backs this up, know that what's happening within the walls of our clinics and healthcare systems is only responsible for 10 to 20% of someone's health and well-being. It is much more largely these social determinants of health that influence what we're doing. And so as I think about, and I look at if I look at just Ohio, Franklin County, the same areas in which we have, if you look on the left, where 4+ chronic health conditions like diabetes, heart disease, kidney disease are at their worst, those blue highlighted areas, if you start to track across the other three graphs there or figures there, you'll notice that those same areas that have the high burden of disease also have very low opportunity, economic viability that is, also have low health opportunity, but also social vulnerability, high social vulnerability, meaning that they are vulnerable to disaster if there were to be both economic or health disasters such as COVID-19 occurring in their neighborhoods. Now, some of you, I understand that there may be some people that say, well, Doc, look, I understand what you're talking about with social determinants of health. I can understand how they relate to patient care and my well-being. But have you seen my inbox lately, my email inbox or my inbox for patients and how many messages I'm getting? Have you seen my grant deadlines? Have you seen the students I'm responsible for? Have you seen my teaching schedule? Is this really my lane? Well, let me take you to one article that was published pre-pandemic. And this person titled the article, "Take 2 Aspirin and Call Me by My Pronouns." He says that woke medical schools curricula are increasingly focused on social justice rather than treating illness. So some pandering there. And I took one of the quotes and said, why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients? He goes on amidst the pandemic, couldn't stop there, and says medical schools need an overhaul. Doctors should learn to fight pandemics, not injustice. And one of many disturbing quotes says, above all, the medical profession should abandon the fantasy that physicians can be trained to solve problems of poverty, food insecurity, and racism. And notably, this came from a former associate dean of a school of medicine. And I understand, certainly, we have a lot on our plate these days. And there is such thing as burnout, and burnout is real. but I suspect we're also suffering from moral injury, not being able to do the things that brought us into careers in medicine and health and science and do them proficiently without having to be burdened by these other things that are happening that impede our impact at patient care or impact at community engagement. And I think about, I reflect on, there was an article in Annals of Internal Medicine, I think 2019, and it was called Sir William Osler, Would He Have Made His RVUs? And basically what that means is a lot of times we're spending a lot of time focusing on how we're going to make the money for the health system through RVU generation. And we're focused a lot on the return on investment, but we're not as focused on return on mission and returning to that thing that brought us to have the impact in what we're doing. So I contend this is our lane. I think understanding the social drivers of health is key. Understanding the social drivers of health is key to us actually being effective in what we do. And I like this quote. It's that it's not peripheral or tangential to health. It's key to diagnosing and meeting a patient's fundamental needs and to restoring health. So I think about our moral determinants of health. And I returned to an article that I first saw from Dr. Don Berwick. He's a leader in healthcare. He started the Institute for Healthcare Improvement in Boston. He also ran for office in Massachusetts while I was there doing a health policy fellowship. And in this article called The Moral Determinants of Health, I just pulled one excerpt. I highly recommend you read this article. It says, in any nation short of dictatorship, some form of moral compass, implicit or explicit, should be the basis of a just society. Without a common sense of what is right, groups fracture and the fragments wander. Science and knowledge can guide action. They do not cause action. And so as we think about the moral determinants of health, these are the values that we decide will be the foundation of our work, of our policies, of our investments. These are the emotions we bring to work, that shared commitment to speak and act. And it's the love and the compassion and the mercy and the kindness, togetherness and human solidarity that we foster in our workplaces and in our work. How do we do this? It's through proximity. Proximity to those we're serving, getting close to those who are made most vulnerable, amplifying their voices. And how can we do that? We must speak, we must write, we must work, we must vote, y'all, and engage. Certainly, as I think about community outreach, and I talked about this in my last talk, community outreach, that's things like your health fairs. Your church might throw a health fair and ask you to come in and check some blood pressures or do some finger sticks to check for blood glucose, diagnose diabetes. Whereas community engagement is a sustained relationship. It's not transactional, it's not short-lived. It's something that's sustained and mutually beneficial. For those of you who may not be following closely, I'll put it in other terms. I'll put it in culinary terms. So some of you may recognize this picture. Guy called Salt Bae via social media. He became a viral sensation for taking the finishing salt and sprinkling it, bouncing it off his elbow into the steak. And that's kind of what community outreach is. Everything's already done. We've arranged the health fair. All you got to do is come in. So we're just putting the finishing salt on that. Whereas community engagement, I'll borrow from French culinary terms, is the mise en place. The table is set with everything, prepared from the beginning for what we're going to do together. It has the community, it has the science stakeholders, the medical professionals at the community together to execute the work together in a sustained relationship fashion. That's community engagement. And so how do we engage around this? I'll give you a concrete example. So I shared this in the last talk. These are architectural drawings. And I'll tell you, as a clinician, as a physician scientist, I had never worked with the architectural firm until recently. But on the left, you'll appreciate the architectural drawing from a Martin Luther King Jr. Library, one of the first in the nation, was in Columbus, Ohio, and it was vacant. They built another one. And so OSU acquired this building, but we didn't acquire it and then assign it to be a new emergency department or a surgical center. We went to the community first and said, well, what do you need and what do you want this to be used for? And they said, Doc, we need help with food insecurity. We don't have a fresh food market nearby. We don't even have a restaurant nearby. Matter of fact, we're going into OSU Hospital East in the first floor where they have the cafeteria. If we want to dine and really get amongst colleagues, we're going to have a demonstration kitchen where people can prepare food to optimize nutritional value. We'll have a fresh food market there and a retail cafe and conference rooms. But it was doing this through centering community voices to make this happen. And certainly, I think about academic, community, and government partnerships. We got to engage people across different sectors, whether it's through our extension centers, whether it's through our advancement, whether it's through our government affairs offices to impact change. One of the things that we did was to disseminate community care kits in 5 target zip codes in those same areas I showed you that were high burden of chronic disease, high burden of COVID-19, high burden of social vulnerability, to give out community care kits that contain masks and hand sanitizer and hand soap and dental hygiene items. Because as we emerge from the first surge of COVID-19, people, essential workers, bus drivers, taxi drivers, grocery store workers, those who were working on the front line said, "Doc, I know what I need, but I can't afford it." And so we got together with large companies like L Brands to give us the hand sanitizer. We partnered with our government agencies to be present and help facilitate the work. We partnered with community organizations to rally people across the community to come and receive these items. And we gave out 40,000 masks, 18,000 hand sanitizers, 12,000 dental hygiene items through these community care kits. And not only that, then our governor adapted this model to be able to do it more widely in Ohio. But part of engaging is also fostering relationships, finding points of intersectionality with your work or your specialty and that of the interests and priorities of the community. I shared in the last talk that through the African American Male Wellness Agency, one of their focuses is targeting changing premature death amongst African American males. And Mr. John Gregory, the founder, is really convinced that we have to change the narrative around heart disease and diabetes if we are going to make significant impact. Well, here I am as a gastroenterologist, right? My expertise is not cardiovascular disease. My expertise is not diabetes, but how do we find that mutually beneficial area where we can work together and make change? Well, one of the things we did in partnership with the community organization, in partnership with students, was to do a systematic review to look at what community-based work had been done to address this amongst African-American male population. And we identified the American Heart Association framework, Life Simple 7. I identified 7 factors total that decrease the incidence of heart disease and diabetes, but also for me as a gastroenterologist, someone interested in colorectal cancer, decreases incidence of cancer too. So found the intersectionality. And what we found in this systematic review is that hardly anything that had been done that worked well for African Americans, that was successful in African Americans attaining ideal cardiovascular health. So we turned this research opportunity, this community-based research project, to a grant, and a grant that funded a project where we took 100 African-American men with less than 4 ideal cardiovascular health metrics through a 24-week intervention of exercise with personal trainers and education with all the partners you see at the bottom. And we navigated these men to getting primary care, to navigating them across social determinant of health barriers that impeded their health and wellness, to engaging in teams with other men via Zoom and sometimes in person, socially and physically distanced, to execute their exercise plan, but also to enroll them in clinical trials, to help them become champions for clinical trials, because we know there's a lack of diversity in clinical trials. But that's through community engagement and finding opportunities for intersectionality. But if we're going to do this work, we have to be committed to diversity and inclusion. We have to create and support pathways at the earliest stages of education. These are some of the themes from a paper I wrote with one of my mentees, who's now a faculty member at Brigham in Massachusetts. And we really wanted to stress how people can move from the idea stage to the action phase. And as you think about where you are as an institution, as a division, as a department in a college, about ways in which you can move from the ideas to the action, think about these tips. Supporting pathway programs, incorporating holistic review and implicit bias training into recruitment, particularly on selection committees, encouraging mentorship and sponsorship. And yes, again, I want to stress implicit bias training for faculty, staff, and trainees. And when I talk about engagement and pipelines, this is a program that I have the awesome pleasure of being an advisor for, called the Heads Up program, or Health Education and Development Services for Underprivileged Youth. And these are elementary and sometimes middle school students that we expose to careers in medicine and science. They get to dissect the brain, get to dissect the heart. They get to use bones and understand how their health relates to what they're seeing in their communities and how to prevent some of the chronic diseases. They get to see themselves in medical students that they may not otherwise be able to do. I'll tell you, the billboards outside some of these communities don't show doctors that look like them. What comes on TV in the commercials aren't doctors or scientists that look like them. So sometimes if you can't see it, you can't be it. So part of it is building the pathway and the pipeline to be more visible and it foster a more diverse and inclusive environment. And we know that diversity and inclusion matter. It drives excellence and innovation. This isn't something I'm just saying. There's evidence to back it up. Certainly in the clinical environment, we know that it improves patient-physician communication, being in a diverse, inclusive environment. We know that race concordance between physician and patient improves the quality of care for some conditions and better health outcomes. But don't mistake this. I'm not saying that every patient should have a physician that looks just like them or that patients should preferentially pick a Black doctor over a white doctor, but we do know that it does matter and there's evidence to back it up. But also as we think about our learning environments, we know that those environments that are more diverse and inclusive foster creativity and problem solving. They're more prepared, the students are more prepared to go into the wards and provide care. The educational experience is more cultivated as far as diverse experiences from not only their colleagues, but not only their staff and faculty, but their patients as well. And albeit we don't like to really harp on US News and World Report rankings, those environments that are more diverse and inclusive do have higher academic reputations. As we look across our landscape, I showed you a picture of the United States earlier as it pertained to where we stand with life expectancy and health conditions, but where do we stand with diversity? We got a lot of work to do, y'all. If we look at Hispanics represent 18% of the US population, but only 6% of physicians. African Americans, 13% of the population, only 5% of the physicians. Persons living with disabilities, 8% of the population, and 2.7% of physicians. And I can go on and on. There is a lack of diversity. And let me take for a second to talk about African American males, particularly as we look at African American males in medicine, or those who are particularly in academic medicine as physicians, staff attendings, et cetera. It's an emergency. There's only 2.8% of academic physicians who are African American males. So it's almost like when you're seeing African American male physician in academic medicine, you're seeing a unicorn. So what can we do? Where do we fall short when we're recruiting talented trainees from URIM backgrounds, and what can we do to change that? Certainly, there's an opportunity to recruit through pipelines with historically Black colleges and universities. Whether we're working at the college level to recruit medical students, looking at our colleges such as Howard and Morehouse and all of these different historically Black colleges to recruit talent. We can't just rest on our laurels that we're a great college of medicine or a great medical school. We have to actively go out and recruit these students and build bridges between these universities that are excelling and producing doctors. Again, I want to emphasize, we have to do better with implicit bias training for our admissions and interview processes. So for those of you who are not familiar with implicit bias, these are unconscious associations, learned associations that impact our decision-making, whether it's at the bedside with patients or in our admissions or reviews and interview requests. Take, for example, this gentleman. This gentleman has, the Black male, he has taken the time, he's pressed his suit, he's showing up for his medical school interview, he's got his tie, got a fresh shirt on that he just ironed. He called his mom to make sure that his teeth looked white. He practiced his expressions. He's gone through the rehearsals in the mirror about how to respond to questions. He's practiced his handshake, previously when we weren't socially distanced, right? He's practiced his handshake with his friends and colleagues. And his interviewer says, you know what, I'm going into this, I'm going to review everything by the book. Objective measures, references, personal essay, academic record. But what is his implicit mind saying? His unconscious mind. His unconscious mind is associating this face, this Black face, with danger, violence, misery, fear, non-compliance. how do you think his unconscious mind will play into his review of this guy's application? Implicit bias mitigation is extremely important. And then lack of holistic review. So we think about, and the data is compelling, that MCAT scores, USMLE scores do not dictate who's going to be a good physician, who's going to be able to provide high quality, high value care. We can't put all our eggs in the basket of standardized test scores. We must do more holistic review when we're reviewing candidates. And certainly, if we are going to improve the pool of candidates that we have from underrepresented medicine backgrounds, we have to be intentional. We have to have data and resource-driven strategies to cultivate diversity. And as we think about the pipeline from applicants to matriculants to residents to faculty to full professor and dean, chancellor, president in our institution, I want you to think about that in your college or those of colleagues across the nation that you know. How many of these people who are dean or chancellor or full professor are women? How many of these are Latinx? How many of these are African American or other? Think about the diversity or lack thereof that you're seeing in your institutions. We must fix this leaky pipeline, and it's through intentional programming and investments that we'll do that. But once we get the talent, once we get the faculty from underrepresented minority backgrounds, where do we fall short? Where do we need to spend some energy? Certainly, it can be isolation. Like I said, sometimes seeing a Black male in academic medicine is like seeing a unicorn. But once you get that Black male into your staff, how do you make sure they're not isolated? How do you cultivate an inclusive environment so they feel included, so that they feel that their ideas, that their voice, that what they want to do with their career is being fostered and nurtured and growing in that soil of your institution? Are they taxed? Yeah, there's such thing as a minority tax, meaning that they come in and then they are automatically the person that's supposed to start the recruitment or start the diversity, equity, inclusion efforts. Not only that, but they aren't necessarily given the time, the FTE, the protected time to do that effort, right? It's supposed to be something that they do in their own time. But diversity, equity, and inclusion is everyone's business. Everyone needs to be invested in pushing that forward. It can't just be the tax on the few. There's a disparity in mentorship and sponsorship. How are we valuing those faculty who are coming in? How do we guide them to advance and be promoted and to achieve whatever they want to do, whether it's in clinical science, basic science, community engagement? How are we rewarding that? But mostly when we look at our PNT, our promotion and tenure criteria, are they included? Is there community-based participatory research? Is that rewarded just as much as basic science? Are we valuing their advancement? How can we revise what we're doing to promote more inclusive environments and value the faculty that we get from underrepresented medicine backgrounds? Certainly, part of what we need to do to engage around this is around anti-racism. And certainly, it's not enough to just say that I'm not racist, but anti-racism means you're actively working against racism, meaning we're reviewing everything from our education to our policies to our practices, and we are centering it in investments of money to do so. And really, here at Ohio State, one of the things that we've been doing in our anti-racism action plan is really across our enterprise, and I'll show you a figure around this, is really elevating the cause, engaging our stakeholders, internal and external, equipping our team members with the resources they need and empowering them to make change, but also evaluating our progress over time. Certainly, this couldn't happen without governance. And from our chancellor all the way to students and learners, they are engaged in our action groups. We have 9 action groups, 160 people are engaged, from trainees to senior leadership, whether it be things around education and training of our med students to make sure they have structural competency that is touching on anti-racism and social determinants of health, or whether it's looking at resources and external partnerships, even things like our supply chain. Are we getting vendors who lead minority-owned businesses for some of our supplies? How are we communicating across our organization? What do our analytics and evaluation say about our environment and how we're addressing health disparities and anti-racism? So across every aspect of our enterprise, we want to be anti-racist at our core, and that comes with intentionality and investment in resources. But lastly, not only must we engage, we speak, we work, we write, and I've been showing you things about speaking and working and writing along the way, but we must vote. not only just our presidential elections, right, but your local elections. Your voice matters, and your patient's voice matters too. And that's why, particularly we in our IHIS is what we call our EPIC platform, or our electronic health record platform. We've embedded smart phrases to be able to send notices to our patients about voting, to ensure that we've documented that we've had conversations with our patients about voting, because we believe that amplifying voice matters, not only for our communities, but also patient care as well. So I'm coming to a close really soon. I'm going to open up for questions and comments and feedback. But at the outset, I told you about who I am. I told you that I'm a man of faith. I told you that I'm a father and a husband. Part of being a father for me is story time at nighttime. I have long days, and so when I come home at night, sometimes I'm getting home right in time for dinner and story time. And one of my favorite books, I can't say it's one of my kids' favorite books, but one of my favorite books to read to them is What Do You Do with the Problem? It tells the story of a young boy who one day realizes he has a problem. This problem is signified by a dark cloud. And the more he tries to avoid this problem, he tries to hide under rocks, run from it, the larger the cloud becomes. And one day he decides he's going to face this cloud. And when he does so, he has a revelation. When he does so, he says, my problem wasn't what I thought it was. I discovered it had something beautiful inside. My problem held an opportunity. I submit to you that we all face problems, whether it's racism, whether it's social determinant of health, barriers to health and wellness, whether it's things that are happening inside or outside of our institution, we face problems, but these problems also hold an opportunity. What are you going to do with your opportunity? I submit that we're going to improve social terms of health, that we're going to make change in our healthcare landscape. It's going to be improving the social terms of health, but it's going to be through us really digging into our moral determinants of health, those values and emotions that we bring to our work each and every day. It's going to be dictated by how we engage, how we speak, how we work, how we write, and yes, voting as well. Now, we may have all come on different boats, but we're all on the same boat now. And for some of you, you have been privileged to not experience some of the disparities that I've highlighted today, but I submit that you should have no comfort that the hole in the boat is not on your end. We're all in this together. But for my students, know your why. This was me as a med student graduating from med school on the day of match day, getting my assignment for getting my first choice in residency at Duke for internal medicine. Looks like I was the first person to jump up that day. I was so excited. But it was because of a couple of things. It was because I had followed a path I felt I was called to. It's because I had mentorship and sponsorship. And you'll see that my career evolved over the way. And in part, throughout all of it, it was doing the thing that made me come alive to impact the issue that breaks my heart. And as I think about the work that I'm doing now, the work that I highlighted for you, it has all been centered around doing the thing that makes me come alive to impact the issue that breaks my heart. I think that's important for all of us. No matter what stage of career you're in or training, do the thing, as Sean King said, do the thing that makes you come alive to impact the issue that breaks your heart. I couldn't do what I do without a large team. These are just some of the faces of some of the people I get to work with some of the work that I highlighted for you today. But it's a community effort. It's a huge team to accomplish the work. This is my family. I'm thankful for this time I had with you. I look forward to engaging with you more in question and answer. So thank you.
Thank you so much, Dr. Gray. That was just incredible. And I think we'll all agree that just the insights that you share and the perspectives and the ideas have just been so inspirational. So there's a few questions in the chat, and then we can open this up to others that want to just unmute and mention or ask some questions. So let me see if we can find the first one here. Let's see. I think this first comment kind of came from me. So you were talking about some of the space that you were redesigning and the influence and just the relationships you developed with the community in terms of designing that. So it seems like physical spaces and proximity are just so essential for that relationship building and those going hand in hand. So I was just curious if you had any more comments about that and how that can be reflected in other ways. Did we lose him?
I think he was kicked off in the last session as well, and he joined right afterwards. So it might just take a couple seconds for him to.
There he goes. Yes, yeah, he had been.
So I actually pulled it up on my phone because I could see that. I'm glad we made it at least through the lecture. So I'm on my phone. I apologize for how it looks right now.
Oh, no problem. No problem. Yeah. I was wondering if you caught the question or the comment.
I did not. It literally cut off right when I ended. It cut off.
Okay. Well, yeah, so glad we made it through your lecture too. So I was starting with the first question. You gave that nice example of how you had this physical space available at OSU and you connected with the community to design and repurpose that. And my comment was it seemed like the physical spaces and the proximity were just so essential to go hand in hand with relationship building with the community. And if you had any other thoughts or insights about that or other examples.
Yeah, absolutely. I think that was extremely pivotal. That library was a community hub. And so, and it's also located on what we call the Near East Side. And the Near East Side of Columbus is where we have highest kind of morbidity and mortality, even thinking about things like infant mortality and thinking about things like food insecurity. And so it was really important for us to really center that community and their voices as we think about how we can move from being a repair shop as a healthcare system to a kind of prevention shop. And that's where healthcare is moving. It is moving more from the traditional repair shop model to being around prevention. And so really centering community voices around that. And we're trying to grow in that space. And so, yes, we have other examples of how we're centering community voices to enact change, whether it be through new grant opportunities for, as we think about COVID-19 and what we're doing around COVID-19 vaccination and opening up other sites outside of our main site, but trying to figure out how can we always center our community voices in the work that we do on a regular basis in ways that we haven't done before.
Wonderful. That's great. Let's see here. Sorry, I've lost. Our chat is growing so quickly. I have to find where that was at. So what suggestions maybe do you have for incorporating training or integration of these social determinants of health into the medical school curriculum? Does that work best in case studies and service learning, elective rotations? What experience have you had with best practices for that?
Great question. I think there's a growing area of literature around structural competency, particularly as it comes to medical training. So thinking about medical students in their curriculum, having specific courses around social determinants of health and around the impact of racism on health is key. So acquiring and cultivating the talent and faculty to kind of teach those lectures, or even having visiting people to give lectures around that is key, so that they can start to cultivate that mindset as before they even enter the wards is extremely important. So yes, there's that structural competency component to the teaching and education that's critical. Also, there's opportunity to bring the community in. So I think about a couple of things. So I help teach a class around social determinants of health, but also one of the things that we do in this class is we bring community members in. So community members actually come in and they share stories about their engagement or encounters with the healthcare system. And then students can ask questions. Maybe it's a case study about their journey through cancer. I think about one example. We had a Somali woman come in and talk about her engagement with another healthcare system, then coming to ours, the differences between the two and what made a difference in her care journey to medical students. They asked questions, and for her, that was such a highlight. Not only was it a highlight for our students, it was a highlight for her to be involved in the next, the matriculation, the next generation of healthcare providers. And, we had a translator there because she did not speak English.
And so that's another opportunity for students to see, how, we bring different voices into our learning, into our health system, and also how we need to be more accommodating for patients who come from different backgrounds. So I think, yes, it's case studies. It's what we do actively through our teaching that make the difference in it. Even as we think about things like whether it be on the wards or what we have standard as grand rounds, there's opportunity to do equity grand rounds, or there's opportunity to, spend a day when you're on the wards to do equity rounds on the wards, as opposed to maybe picking a topic, whether you're talking about cellulitis or ulcerative colitis or what have you as a topic on rounds that day, maybe picking some patient cases and really digging into the social determinants of health. Well, why do you think this patient has been battling with getting their medication? And digging into some of the underlying causes about where they live, or what their income is, or what jobs they hold, or how they don't necessarily have childcare to get to the appointments, or how many buses they have to take to get to the clinic, things like that. So taking those opportunities.
Wonderful. Yeah, maybe to follow up on that, Dr. Hampton had a follow-on point. I don't know if you'd like to explain that a bit further.
Did I miss that?
So it's in the chat. We recently had a talk from, sorry, that's my husband. We recently had a talk that was given at another meeting, and what the gentleman showed, and Ruby may be able to explain this a little more as well. What the gentleman showed was that there are fairly significant disparities when you look at people coming into med school in terms of education and test scores, et cetera, but when you even the playing field and give everybody the same access to the same information, what you see, especially as it relates to ITE exams and those sorts of things, is that those students who were behind and were probably considered less able to do the work, they catch up very quickly, and everything is more related to the complication rate of the institution that you were practicing at than it is to MCAT scores or those sorts of things.
That's absolutely correct. And that's what the literature is telling us too. And so, that's what I'll tell you and I'll just give you a personal example. That picture I showed you of me getting accepted to my first choice in med school, my first choice in residency at Duke, I know it wasn't because of my test scores. I did okay, but I wasn't any more stellar than I think people who are trying to get that residency spot or one of those spots. It was because Duke intentionally did a holistic review. They weren't just looking at my standardized test scores. If they only looked at that, I wouldn't have made it. And I think that was a pivotal part of my career. It's interesting because last month I gave their MLK grand rounds. And so it's quite sentimental to me that, in a situation, I was coming out of a historically Black university, Howard University College of Medicine, going to Duke, a nationally ranked excellent program in internal medicine for residency. And to be, coming from, having a very fulfilling and rewarding career, it was because people, took chances and looked beyond just my test scores that gave me the platform. So I encourage, those who are on selection committees to do the same.
Good.
And just to kind of piggyback on that, I work with the family medicine residency here at Carle, and the interviewees will make all these, comments about their test scores, and I say, you know what? I know that my colleagues are really, really into people's test scores. I haven't actually looked at your test scores, so I'm just trying to kind of get a feel for you as a person, as an individual, because that also, like, if you get great test scores but patients hate you,
right,
or you can't connect with them in a way that makes them want to work with you. It doesn't matter what you know.
I think about there's a quote, I don't know who it started with, but there's a quote that says, people don't care how much you know until they know how much you care. You have to be able to communicate with people and establish a rapport with them before they'll start accepting anything you're going to recommend to them as treatments or assessment or diagnostic or management plan. So yeah.
I think that's Maya Angelou.
Oh, might be.
Very good. So another question, just going down the list. This one's from Dr. Knight. Who was involved in the decision-making to allow voting messaging into the EMR?
Oh, it started with Woese. So I'm part of a close cohort of colleagues who were really active around voting. And we literally just took it up the chain to the highest levels. We even went to our chief of IT, data analytics as well. And we said, this is important. This is why it's important. We built a case around it, and it was done. But it was because we were the squeaky wheels. We used our voices and said it's important that we do this. So we went to our CEO, went to our chancellor, we went to a dean of College of Medicine, and then we went to our IT folks who were interfaced with Epic, and said, we need to, this is why we need to do this. And we added smart phrases to be able to do that.
Wonderful. Okay, another question. As we build out opportunities for donors to engage and work around health disparities, how do you see technology and innovation playing into that and into the social determinants of health?
Oh, all of these are wonderful questions. And it's so important in this work to maintain relationships, particularly at the institution, with advancement and with government affairs. So advancement, they often interface with donors, particularly in this time, where really social activism has reached a high it may not have seen since, the 1960s and 70s. People are wanting to give towards this work, particularly as it impacts the health of diverse communities. And so it's so important to amplify your work and share the work that you're doing in community or in health and healthcare and addressing social determinants of health with your advancement team, because they can connect it to the donor. So that's what we do. So we, particularly in this time of technology, to direct the question, our advancement team actually has, and I forget the name they call the series, but they have an active ongoing series where they do webinars, like these evening webinars that they send out to all of their donor base. And it's a time for clinicians, for scientists to really talk about their work, but for donors to see opportunities where they can give. So our advancement team started this webinar series. I spoke on one or two, but also they provide opportunities to also talk with donors. So literally just last week, there was a donor who was interested in some of the work we're doing around building, creating that healthy community center that I mentioned to you, and wants to have a conversation. So leveraging Zoom to have those conversations with potential donors, I think is really important. But thinking about ways that you can leverage Zoom for webinars or conversations with donors and working with your advancement team is critical to sustaining the work. Yeah.
Excellent. So a comment from Dr. Mendenhall, just saying you're making excellent points that we in our College of Medicine are incorporating concepts such as structural competencies into our medical humanities curriculum. And in fact, that we hope to have communities come to our classes as knowledge experts. And maybe that's a question to you in terms of, have you implemented something like that?
Yeah, I think like that social determinants of health class I was mentioning, where we bring community members in. I think that's extremely important. And that's because they bring an expertise. And it's important for our students to see that our students who are learning science are going to become physicians or other healthcare providers. They aren't the experts in everything. And, when I'm partnering with communities, I was just writing this commentary piece that we're trying to get published, where the opening quote is one that the community partner, Mr. John Gregory, who I showed a picture of, he said, I remember this one of the days we were sitting at the table trying to design this work. He said, you guys are the experts in science and medicine. I'm the expert in the community. And he's so right. I mean, people have a lived experience that our students, our trainees, our staff, and our faculty aren't experts in. And so it's so important to bring that expertise into our classrooms and into our kind of virtual space for communities to share their expertise with us so we can learn.
Yeah, and then also, if I could say, they're also experts in terms of health and wellness too, right? Like when they experience extreme stress and other things, the things that they do to cope and to remain calm, that those are really important to understand as well. And then their connection to health disparities related to stress and other things. So.
Oh, absolutely. Absolutely.
Yeah. And so my one of my big ideas is maybe trying to get a cohort of 100,000 community health workers and working with Morehouse and doing that, right? You know, they have the community health workers program. So
yeah, fantastic. I mean, I'll tell you, and you may have seen this. So Morehouse, as well as other historically Black colleges, universities, med schools, including Morehouse School of Medicine, you know, a lot of people are investing a lot of money, millions and millions of dollars now, from banks to corporations to even health centers. So you may have seen this happened maybe a month ago or so. Common Spirit, which is the largest kind of Catholic health system, if you will. It was a merger between Dignity Health and Catholic Health Initiatives that formed Common Spirit. They invested, I don't know, it was over $10 million or so in Morehouse School of Medicine. And so there's a lot of resources as you think about partnerships with historically Black colleges and universities to leverage in doing some of this work.
Yes, thanks.
Yep.
Wonderful. So those were the questions in the chat, but we've got a few more minutes. Any questions from the audience? People can just unmute yourself and please ask.
Yeah, Stephen, this is Tahir. Such a wonderful, inspiring talk. Really, this makes my day.
Thank you.
You know, over the last 1 year, I'm from engineering, and we have been thinking within the College of Engineering that, you know, given what we have seen the last 1 year or maybe many more years that we haven't seen before or noticed before, is that maybe we cannot teach engineering or medicine the way it used to be. You know, with a blind eye towards social injustices and disparities. Where should we start? And many of us in engineering, we were not born and brought up in this country. And I'm finding extreme difficulty in understanding the origins of many of the injustices. Where do we start? At least in the science domain.
Yeah, great question. And it can seem, you know, overwhelming, particularly for, like you said, someone who is not native to this country coming in and trying to understand the nuances of kind of a long legacy and history of social injustice and systemic inequity. And I think it first starts with dialogue. And sometimes that could be simple. Well, I should say simple, but none of it is simple. But as simple as, you know, hosting conversations, whether they be listening sessions. So we, you know, in the wake of George Floyd's death, across our enterprise, whether it be at the department, the division, or the college level, we had kind of conversation, listening sessions where people kind of talked about what that tragedy meant to them, but where we as an institution, as a department, division, can go in creating more inclusive environments, in combating racial inequity, and tying the work, you know, to what we do on a daily basis. So dialogue, listening sessions like that, bringing in content expertise. Maybe it's people who have worked in engineering, but also have tied their work to addressing social injustice to kind of share ideas about what they're doing and how they've done it. But I think dialogue through kind of ongoing conferences, dedicating conferences that may otherwise be to, you know, maybe you have a weekly conference or a monthly conference where you talk about specific engineering topics, but dedicating someone specifically towards social injustice and tying that to engineering, for example, is key just for learning, because it has to start with learning. And then, you know, I think also just trying to invest, whether they be your colleagues, and trying to get to know your colleagues or trying to get to understand their lived experience. You know, certainly it's a little bit more difficult to take people to coffee now, but certainly Zoom has made it easier to connect with people about how you can talk about these issues. And then, you know, the other thing is reading. I've become more of a fan of audiobooks recently. You know, I think about things that I've read recently that really allow me to make ties. Like I think about one book I just read by Daniel Dawes called The Political Determinants of Health, and talk about how policies past and current impact health of people. Or I think about a book like The Color of Law, that talked about how changes in law, particularly around redlining, or how we structured home ownership and mortgage loans, particularly, and restricted those for people of color, and how that impacts their health. I think about, books that help me to learn about this. So I think it really starts with conversations and dialogue, and it can seem like daunting, but really that's where the idea generation comes. So I would start with trying to create a space for that dialogue, whether it be in grand rounds, conferences, in the College of Engineering, and that's, exchange ideas about how you can move forward in addressing them.
Thank you.
Yeah, thank you.
Well, thank you so much too. And I don't know if you've been watching the chat or if you see that, but there's just a number of different accolades and appreciation and thank yous coming in. And I'd just like to second that. I think this has been a wonderful 2 hours, and we have so much more, I think, to learn and go by. And you've really inspired, I think, many of us. So thank you so much, Dr. Gray. We'll continue to follow your work and look for change.
Thank you all so much. I've been really excited to be with you today. Again, I apologize for the technical difficulties, but this has been a lot of fun. And thank you for all the questions. You all have a blessed rest of your week.
Thank you.